Kia ora everyone and welcome to this MedTalk on diabetic kidney disease. My name is Dr Grace Lee and I'm here with Dr Hari Telreja. Hari is a renal physician at Counties Manukau Health and Ormiston Specialist Centre. Today we'll be talking about diabetic kidney disease with a primary healthcare lens. We'll be identifying those at risk, going through a renal assessment and best practice management, finally with some take-home messages. Welcome, Hari.
Thanks very much, Grace, for having me.
Diabetic kidney disease. It's of particular concern for our Māori and Pacific community. What is the extent of this problem in New Zealand?
So diabetic nephropathy is one of the important complications of diabetes, and it is the number one cause of end-stage kidney disease in New Zealanders. Diabetic nephropathy is of a particular concern in Pacific people and Maori who are at high risk of developing chronic kidney disease because of diabetes. Also, end-stage kidney disease because of diabetic nephropathy is more common in these populations compared to New Zealand Europeans. So to give you a sense of the problem in these populations, in a 2011 study by Kenyali and colleagues in type 2 diabetics, microalbuminuria or macroalbuminuria was present in almost half of Maori and Pacific people compared to just about 28% of New Zealand Europeans. And after adjusting for all the other risk factors, the odds of advanced albuminuria was 3.9 times for Maori and 4.7 times for Pacific people compared to New Zealand Europeans. And let's say roughly a third are going to progress into advanced stages of chronic kidney disease, and some will progress to end-stage kidney disease. So if you look at the 2017 ANS data report, diabetic nephropathy was a cause of end-stage kidney disease in roughly 70% of Maori and Pacific people, compared this to about 36% in New Zealand Europeans. Hence, Maori and Pacific people are considered at a high risk of developing chronic kidney disease due to diabetes.
We have the capacity to assess renal function in primary care. What are your recommendations for a full renal assessment?
So firstly, we need to identify the patients who are at risk of progressive CKD. So remember the risk factors: diabetes, hypertension, obesity, presence of proteinuria, age more than 60, family history of chronic kidney disease, history of smoking, use of nephrotoxic medications, and ethnicities, which include Pacific people, Maori, and Indo-Asians. Then we need to screen for presence of microalbuminuria. So first morning sample urine albumin to creatinine ratio, along with the blood test for serum creatinine and glomerular filtration rate. These need to be done at the time of diagnosis of diabetes and at least annually after that, more so if the tests are abnormal. Thirdly, we need to remember to check the blood pressure on a regular basis. Remember, the blood pressure target for diabetics is lower at less than 130/80 compared to the non-diabetics, except of course for the very elderly who are at a risk of postural hypotension. Now, these days we can also predict the risk of kidney failure by using simple and validated calculators such as kidneyfailurerisk.com.
Microalbuminuria is an important screening tool. What's the significance of it in diabetic kidney disease?
So microalbuminuria, which is now called as moderately increased albuminuria, is an important screening tool to assess end organ damage because of diabetes. So in patients with type 2 diabetes mellitus, a microalbuminuria is associated with increased cardiovascular risk of CKD progression, as well as higher risk of mortality. However, in elderly patients with type 2 diabetes, microalbuminuria may be associated with increased cardiovascular risk, but not always associated with CKD progression. And in the elderly population, even without type 2 diabetes, microalbuminuria may be present, which is common, and it may be just reflective of other processes in the kidney, such as benign nephrosclerosis. However, it's important to remember that regression of microalbuminuria can occur just like in type 1 diabetes, and the factors associated with regression include better glycemic control, better hypertension control, use of ACE inhibitors or ARBs, and shorter duration of microalbuminuria. Hence, it's important to target these in patients with microalbuminuria.
From our renal assessment, what components of these do we need to manage, and what is best practice?
So it's important for us to modify all the risk factors, such as diabetes, hypertension, address the dyslipidemia and other cardiovascular risk factors, and also highlight lifestyle modification, such as smoking cessation, as well as weight loss for obesity. Now, in general, the management depends on the urine albumin to creatinine ratio and the serum creatinine. So let's say if the urine ACR is less than 2.5 in men or 3.5 in women, which is normoalbuminuria, and the serum creatinine is less than 150 micromoles per liter, in such cases, we need to keep the HbA1c low. The target HbA1c would be less than 53 millimoles per mole. Treat the hypertension if it's present. So remember, half of them will be having elevated blood pressure before the onset of microalbuminuria, and address the cardiovascular and lifestyle risk factors. In such patients, use of ACE inhibitors or ARBs are not indicated solely for the purpose of primary prevention of microalbuminuria. If there is microalbuminuria, which is defined as urine ACR of equal to or more than 2.5 in men and 3.5 in women, but less than 30 milligrams per millimole, in such cases, we also need to confirm that microalbuminuria is truly present, which means a repeat test is warranted. And 2, try and establish the cause of microalbuminuria. So we need to rule out other factors such as urinary tract infection, contamination with blood, congestive heart failure, vigorous exercise, and some of the other causes of kidney disease. Thirdly, if there is macroalbuminuria, which is urine ACR of more than 30, if that's present, then ACE inhibitors or angiotensin receptor blockers are indicated for antiproteinuric effect irrespective of the blood pressure in these patients. Unless, of course, if there is bilateral renal artery stenosis is present, which would be a contraindication.
Hari, when should we consider referring patients?
So you should refer a patient to a nephrologist when the CKD is progressive, especially when the GFR is less than 45 ml per minute per 1.73 meter square, or if there is evidence of intrinsic renal disease such as glomerulonephritis. Hence, a midstream urine is really important test. Or if the patient has resistant hypertension. And in certain cases, when it's not very clear, you should try and discuss it with the nephrologist over a phone. Now, in certain cases, such as stable CKD3, where we have completed all the investigations and there's a clear-cut plan which is well understood, if this is in place, then you may not need a referral to the nephrologist. Also, if chronic kidney disease is part of a terminal illness, then further investigations may not be appropriate.
Patients with diabetic kidney disease are often on multiple medications, some of which have deleterious effects on renal function. The term triple whammy is often used to describe a combination of medications that can cause acute kidney injury. Can you tell us more about this?
Yes, so triple whammy is the general term which is used to describe a combination of either ACE inhibitor or ARB along with a diuretic and a non-steroidal anti-inflammatory drug. So these drugs, when used individually or as a combination, can increase the risk of acute kidney injury. Now we know that ACE inhibitor or angiotensin receptor blocker and non-steroidals, these drugs reduce the renal blood flow, whereas diuretics can cause hypovolemia. Importantly, NSAIDs can also antagonize the antihypertensive effect of ARB or ACE inhibitors and even the diuretics. Hence, it's very important for us to avoid this combination altogether. If we still have to use it, we must monitor the renal function very, very closely, especially in the high-risk population such as the elderly. Patients who are on ACE inhibitors or ARBs are therefore advised not to purchase the NSAIDs over the counter either as a single drug or in combination. In fact, I would say it's even better to avoid ACE inhibitors along with ARBs in patients where it's not indicated.
Finally, what are some take-home messages?
So firstly, we need to remember early diagnosis is the key. So remember testing for urine albumin to creatinine ratio, serum creatinine and eGFR at the time of diagnosis and at least annually thereafter. Then it's important to identify the patients who are at high risk. Remember, some ethnicities are at a high risk. Thirdly, we need to modify the risk factors. So treat diabetes and hypertension very aggressively, use ACE inhibitors or ARBs, address the cardiovascular and lifestyle factors. Remember, with all these interventions, microalbuminuria may actually regress. Next, We need to avoid the nephrotoxics such as non-steroidal anti-inflammatory drugs. And then remember, all kidney diseases may not necessarily be due to diabetes, and hence you can call your friendly nephrologist when in doubt.
Thank you, Hari, for coming in today and talking about this very important topic with us.
Thank you for having me.